Hi, I'm Dr. Mehboob, MD Ophthalmology from AIIMS, New Delhi, and I have started a series of ophthalmology images. This ophthalmology image series is relevant for the NEET PG and INI-CT upcoming examination. The images in ophthalmology that have been compiled with the thought that this will help you to solve the conceptual based images that comes in the examination, and the whole series is divided into the some parts, and today we are with part 1, which is consisting of 15 MCQs, and in this you will be able to learn the different types of concepts of the different images. So we will go by the MCQs, okay, and I'm sure that you will be able to comprehend the knowledge here. For the upcoming parts and the very interesting ophthalmology conceptual based videos, subscribe our channel and click the bell icon to get the notification. Thank you. So we will start with our images in the ophthalmology part 1. So here we are with the first question. The first question is saying, that what is true about the disease which is shown here in the figure, except, the word except is very important. So the options are here: it is caused by the DNA pox virus, organism shows intracytoplasmic HP inclusion bodies, always developed in immune compromised and spontaneous resolution on its own. So this is the picture. Let me enlarge for you. This is the cluster of the vesicles above the eye. This is below the lower eyelid, and this is the magnified view on the slit lamp, where you can easily appreciate the umbilicated lesions and the vesicular shape. Okay, now what is the diagnosis from this? The diagnosis that you can make here is molluscum contagiosum. Now, once you made the diagnosis of this ophthalmologic disease, now this question has now becomes microbiology questions. So this is an integrated questions, right? So whether the molluscum contagiosum is a DNA pox virus or not? Yes, obviously it's a DNA pox virus. Organisms of this, that is molluscum contagiosum, is actually having intracytoplasmic Henderson-Peterson bodies. This is also true. Always develop in immunocompromised and spontaneous resolution on its own. Spontaneous resolution hota hai. Yes, this disease spontaneously resolve by its own. However, you can also apply the laser to remove this type of lesions. But this option C, always in the immunocompromised, is wrong, because it is also occurring in the immunocompetent patient. So the answer here for this question is this one. Rest of the statements are true. Moving to the second question. Look at the given picture, this picture. The child is suffering from the left eye ptosis. Which phenomenon is being shown below? The phenomena are Bell's phenomena, option A, Marcus Gunn jaw winking phenomena, monoocular elevation deficit, involutional ptosis. Okay, so look at the picture. The picture is showing, the circle is showing that the level of eyelid from this pupillary reflex, see, this is the pupillary reflex, this white dot, and the level of eyelid is and the distance of this eyelid is very short, so it's a moderate ptosis. You can compare it with the right eye. Now see the left eye. After opening the mouth, what is happening? The distance of this pupillary light reflex and this eyelid margin has increased, means it becomes equal to the opposite eye, means ptosis has resolved. So what has happened by opening the mouth? So this phenomena is known as, obviously you must have heard, this phenomena is known as Marcus Gunn jaw winking phenomena. And why this is happening? This is happening because misdirection of which nerve? Mandibular division of trigeminal nerve to LPS muscle. LPS muscles, levator palpebris superioris muscles, will get innervation by this mandibular division of the trigeminal nerve, and whenever there is a lateral pterygoid movement, whether by opening the mouth or by sucking or by moving the mouth to the opposite direction, then this nerve, this mandibular nerve, will get stimulated and it will cause the retraction of the eyelid. Okay, so this is the answer here. Now the option A is Bell's phenomena. You should also know about this Bell's phenomena. Simply when you try to close your eye, the cornea, the eyelid, the eyeball moves upward and outward direction, this direction. So this phenomena is called Bell's phenomena. This is normal. Monoocular elevation deficit. Sometimes what happens, the elevation deficit is there along with the ptosis. So this condition is called monoocular elevation deficit, maybe because of the inferior rectus overaction. Okay, so what you do in this condition, you sometime just before treating in this condition, MED, that is monoocular elevation deficit, before treating the ptosis, you just treat the deficit, monoocular elevation deficit, and after treating the deficit, in most of the time the ptosis resolves on its own. Okay, so if they ask you which conditions to be treated first, whether monoocular elevation deficit or ptosis, you have to say that monoocular elevation deficit should be treated first, because in most of the cases the ptosis resolves on its own after treating this. Now this is about the question number 2. Just look at the picture here. The question is saying that which of the following congenital ocular abnormality is this? Which of the following the congenital ocular abnormality is this? So can you see cornea? No, you cannot see the cornea. Can you see the eyelid? No, you cannot see the eyelid. The eyelid are actually formed by the anterior lamella, and then there is a separation of the anterior lamina into the upper half, making the upper eyelid, and the lower half making the lower eyelid. But yahan pe, in this condition, nothing has happened. So this condition is called, this unfortunate condition rather we can say, is the, what is this? Treacher-Collins syndrome, cryptophthalmos, ablepharon or ankyloblepharon? Cryptophthalmos. So answer is cryptophthalmos. The non-separation of the eyelid is the cryptophthalmos. So what are the other congenital abnormalities that you can see? Common are Treacher-Collins syndrome, ablepharon. In the ankyloblepharon, what happened? Ankyloblepharon may, the chemical injuries, I'm talking about the ankyloblepharon. Ankyloblepharon occur because of the adhesion of upper eyelid and the lower eyelid. When? Because of the chemical injury, blast injury, laceration injury, and in other many conditions like the ocular cicatricial pemphigoid condition, OCP. So these are etc. conditions. So let me show you 2 or more important conditions, that is this one and this one, this two. So this picture is of ablepharon. There is no eyelid, means anterior lamella has not formed here, right? But after reconstruction surgery, see what we have tried to make this eyelid. So this is actually ablepharon. This is actually what? Ablepharon. And this is Treacher-Collins. See in the ablepharon there is a fish mouthing. So this is ablepharon also. And see in this Treacher-Collins syndrome there is upper eyelid coloboma and there is a lower eyelid coloboma here. So this is the another congenital abnormality that can be asked. So that's why I have put the picture intentionally here. Coming to the 4th questions. A patient suffering from continuous watering right eye following investigation is done. What is true? True kya hai? This is the picture. Let me enlarge the picture for you. This is the first picture. This is the second picture. This is the third picture. First, there is a normal CT scan has been normal X-ray has been taken. Now, what is this? This is a CT scan where after putting the dye, you can see in the left side, very well see in the left side, the dye can be visualized very easily, but here the dye has stopped here. No further infiltration by the dye. So there is some obstructions here. So this photograph tells you about the exact position of the obstruction. So what is this investigation? We call it DCG, that is dacryocytography. Okay. Now coming to the options, we will talk about this photo later on, but coming to the options, DCR surgery is the treatment of choice in the children. So you see, DCR surgery is something which is reserved for the adult only. For the children, especially less than 4 years of age, we should not consider DCR surgery. Okay, so this is contraindicated, rather we can say. So obviously this option is false. This investigation done to know the exact location of the blockage, as I have already mentioned that this investigation tells you about the exact location of the blockage. So obviously this statement is true. Third, no dye is used. How can we say that no dye is used? Obviously dye is seen. So this is false statement. Can be done in the regurgitating mucosals. Can you do any interventional thing in infected cases? So how can you do this in this condition? First, resolve this condition, treat this condition medically, and then do whatever you want to do, right? So obviously this is a false condition, false statement. This is question number 4. Okay, now I have to tell you about this. What is this? This is a digital subtraction Dcg. This is a digital subtraction Dcg which tells you about the exact location. See, here is the exact location. Okay, here this is what, here is the exact location. So here you can see the dye, here you cannot see the dye further progressing into the nasolacrimal duct. Now there is one another investigations or photography or imaging, rather we can say, that is called nuclear lacrimal scintigraphy. This is done under more physiological conditions, and obviously when you don't know about the position of by the dye, that is DCG, this can help. Okay, so I have put it because they can sometimes give this photograph and just ask the name. So you should remember the nuclear lacrimal scintigraphy. Now, what is false regarding the following procedure? Done. This is the procedure. What is this? This procedure is the probing, right? For the nasolacrimal duct obstructions, obviously. Done in 2 months of old baby with watering, regarded as a definitive treatment, delayed until the age of 12 to 18 or even 24 months. This is months. And can induce the canalicular ptosis. Let me tell you, done in 2 months of old. We consider that around 2 months of age or 6 months of age or until 1 year of age, the obstruction is mainly membranous. So we recommend that treatment there is Kriegler massage. See there, Kriegler massage. We recommend the treatment is a Kriegler massage. We press here and then move like this direction. Okay, so this is Kriegler massage. Obviously nothing to do with this probing. Probing is not at all done in this condition. So the statement, the false, this is the false statement. So we have our answer here, only this one. Obviously then rest 3 are then true. So it is regarded as the definitive treatment, and we have to wait for until 12 to 18 months or up to 24 months also. If the first probing is failed, we can go for the another probing. Okay, under CT guidance also, but not multiple, more than 2, not more than 2. Why? Because of this complication, canalicular stenosis they can cause because of the injury to the mucosal area. So this is the answer of the 5th question. Moving to the 6th one. All are true except regarding the following picture. This is the picture. What is this instrument? This instrument is called Hertel's exophthalmometer. Hertel's exophthalmometer. What is this? So obviously A is true. Used to measure the interpupillary mid diameter. Just see, the pupil is here and here, but the measurement is being taken from here and here. So obviously this is not measuring the interpupillary diameter. That's why this is the false. Lute's exophthalmometer can also be used instead of this. If you don't have this Hertel's, you can use the Lute's exophthalmometer. So this is right. And what is being done? This is actually measuring the amount of bulging, amount of protrusion of the eyeball. That is proptosis. Obviously, this is the right answer. So we have our answer here is this. This is the false statement. You have to keep in mind that the true except, this is very important. And now the tricky one. Coming to the patient underwent the RTA 2 weeks back and he is having difficulty in downward movement of the eye. What is true except? Okay, the sign is oil droplet side. Most common orbital fracture is flow. Thickest part is lateral wall. Nasolacrimal duct open in middle meatus. Let me tell you. What is this? This is a CT scan because the bones are white. Bones can be seen easily. This is the orbit. This is the flow. This is the roof. This is the medial wall, lateral wall, flow. What is happening here? What is happening here? See, the floor has been breached. So there is some material is hanging in the maxillary meatus, maxillary sinus. This is the maxillary sinus area. This is maxillary sinus. Okay? And some material is being hanging. There is a broken here. This sign is called oil droplet sign, right? Now what happens? Sometimes the inferior rectus gets entrapped in this bony fractures area. So this can cause the difficulty in the downward movement because inferior rectus is being trapped here. So obviously the floor is the most common fracture and this lateral wall is the very thickest one. Coming to the options here, the sign is oil droplet sign. Obviously this is true. The common fracture is the floor. This is true. Thickest wall is true. Obviously we are left with only one option which is not true. That is middle meatus. Instead of middle meatus, it should write inferior meatus. Nasolacrimal duct open in inferior meatus. You can confuse it by the middle meatus because in the DCR surgery, we make a communication with the middle meatus of nasolacrimal sac. What is done in the DCR surgery? In the DCR surgery, we make a communication between the nasolacrimal sac and the middle meatus. But naturally, this nasolacrimal duct, moves laterally and posteriorly to open in the inferior meatus, below the inferior turbinate. So this is the wrong statement that is written and our answer. Coming to this, at the routine checkup, a young boy has a Y-shaped lenticular opacity. He was diagnosed to have the future cataract, which of the nucleus is not involved. Basically, you can you see this Y-shaped cataract? This Y-shaped cataract. So this Y-shaped cataract is formed by the fusion of the posterior nuclear things that is being laid over time, but after the formation of the embryonic nucleus. So obviously the answer is embryonic nucleus. Rest of the points are obviously they have contributed to the formation of this one. Coming to the next question. A woman delivers a baby with a rash below patent ductus arteriosus. What type of cataract seen in this disease? Nuclear pearly cataract, lamellar cataract, blue dot cataract, posterior polar cataract. This one. See the picture, lenticular opacity and some corneal clouding भी देखा जा रहा है यहाँ पे. So this is the nuclear pearly cataract. So obviously the condition that is being said, because the baby is delivered just now and he is having rash, some infection, intrauterine infection, and you know what are the intrauterine infection torch tests that has to be done. Among the torch, the rubella has the persistent, this peculiar feature of patent ductal arteriosus. So the diagnosis that we can make is the congenital rubella syndrome. Now, what type of cataract is this? Obviously, the commonest cataract that can be formed in the congenital rubella syndrome is nuclear pearly cataract. But यहाँ पे this is not it. You have to know some more things. In the congenital rubella cataract, beside cataract, you can have the sensory neural deafness also. Okay. Besides that, you can have the congenital heart abnormality like PDA, patent ductus arteriosus. Okay, PDA. Now, what are they? If somebody asks most common ocular manifestation, then you have to write the chorioretinitis, not cataract, chorioretinitis. And in the chorioretinitis, if they may ask you what is the peculiar feature, it's the salt and pepper retinopathy. This is very important. Now coming to the 10th number question, the type of cataract is seen in type. Obviously, this cataract is seen in type 1 diabetes, Alport's, galactosemia, myotonic dystrophy. What is this cataract? You already know. I know that everybody should knows about this. Just for the completion, I have put it here. This is a Christmas tree cataract. Right? This is a Christmas tree cataract. Christmas tree cataract. So Christmas tree cataract, obviously all of them, you know that myotonic dystrophy is the cause of this. In the type 1 diabetes, you have the snowflake type of cataract. Galactosemia में आपको oil droplet cataract मिलेगा. And sometimes they ask you, this is a reversible type of cataract. Means if you treat the galactosemia in the early stages, you can reverse this cataract. But the fact is that in the advanced cases, it is not reversible. But for the vague term, just for generally, they will ask you which metabolic cataract is reversible. You have to answer galactosemia only. But the fact is, obviously, this is reversible in early phases, but not in the advanced phases. Coming to this, a 70-year-old patient suffer from acute loss of vision and metamorphosia. What will be the fluorescent angiography image of the given below images? You have to answer this. The patient having the acute loss of vision and metamorphosia. See, the word metamorphosia means distorted images, distorted lines. And this occurs only when there is some problem over the macular area. Remember, when there is a metamorphosia symptom, you have to go for the macular disease only. Okay? Metamorphosia is diagnosed by Amsler grid test. So this can also be a question. Amsler grid test. So beside this, the fluorescent angiography image of this photo will give what type of pattern? Can you see this fundus? Can you appreciate something unusual here in the macular area? This is not as pink as the rest of this. Means there is something below the retina, that is fluid. So this is nothing but this is CME, central macular edema. This is CME, central macular edema. And in this macular edema, when you do the fluorescent angiography, you will find pataloid appearance. because of Henle layer only. So they can ask you why there is a patelloid appearance in this CME because of the Henle layer. Okay. The ink blot appearance is seen in CSC, central serous retinopathy, chorioretinopathy. Dual circulation, if you say that dual circulation is a feature of some tumors or abnormal mass. Let me show you the patelloid appearance. See, this is the patelloid appearance on the FA. This is the FA which is showing the patelloid. This is the patelloid appearance. And this is very important to know that because this is most of the time they will ask you this in the examination. Okay, so you have to remember this patelloid appearance of this condition. Now the question, 12 number question is saying what is, 12 number question is, a 72-year-old male comes to the eye clinic with history of the gradual loss of vision. On eye examination there is a posterior subcapsular cataract with fundus changes. 72 साल का आदमी है जो क्लिनिक में आया है, loss of vision is gradual. What is the diagnosis? Diabetic retinopathy, dry ARMD, hypertensive retinopathy or wet ARMD. So see this, see the disc is almost normal, however some disc pallor is there, not significant for us for this question. These yellow crystals. What do you think? This can be, what do you think? This is nothing but, these are the hard exudates. These are the hard exudates. Just see the vessels. Vessels are normal, normally dilated. These are hard exudates and some hemorrhages. If you see clearly, these are the hemorrhages point. Okay. So this is the dot hemorrhages also found. So this most commonly gives to the diagnosis of diabetic retinopathy. Let me tell you why not dry ARMD, why not others. Because dry ARMD have the drusen. This wet ARMD also have the drusen plus atrophic plus neovascularization, NVE और neovascularization. वेट ARMD में ड्रूसेन भी होगा, एट्रॉफी भी होगा एंड न्यूरोवैस्कुलाइजेशन भी होगा. हाइपरटेंसिव रेटिनोपैथी में जो आर्टरी का डायलेटेड आर्टरी जो होते हैं दैट इज एटेन्यूएटेड बट नॉट इन दिस कंडीशन. सो द मोस्ट प्रोबेबल आंसर हियर इज डायबिटिक रेटिनोपैथी. 48 hours sustaining the severe head trauma presented to the eye clinic. On eye examination, fundus finding as follows: hypertensive retinopathy, diabetic retinopathy, personal retinopathy, CRVO. देखिए, you can see in this picture there is a whitish, discoloration of the fundus has taken place, representing some of the ischemic changes have been taking place, degenerative changes have been taking place. So the clinch of the diagnosis is after the trauma, mostly there is a posterior retinopathy is the answer. Why not hypertensive retinopathy? Obviously there is no arterial attenuation here. You can see there is nothing like AV crossings. You can see there is nothing sort of features like hypertension have been given in the history also. Diabetic retinopathy, you should see the exudates, you should see the hard soft exudates, microaneurysm and dot and blot hemorrhages, superficial hemorrhages not present here. CRVO. In a CRVO, all of the area mostly it becomes ischemic type of things, but whitish is not peculiar to the CRVO. So the answer most appropriate to this condition is personal retinopathy. Okay, now the 14th number question is this one. A 40-year-old girl developed rapidly progressive unilateral proptosis in the left eye. There is swelling superiorly which is painless. CT scan image shows below. So can you see here, this is swelling here in the superior area, the dual circulation, the vessels are very prominent here. In the CT scan, you can just see in the left side, there is a homogeneous mass which is actually pushing the eye outward and bulging. Okay, homogeneous mass you can see here, extraorbital portion. Now look at the age, look at the way rapidly progressive, look at unilateral painless condition. This is showing that some malignancy is going on there. So what is this malignancy you suspect here? It is the most common primary intraocular malignancy of childhood. Embryonal type carries good prognosis. Most common site is supranasal. Most common site of metastasis is lung and bone. It's a bone. This is bone. What is the diagnosis? What should you expect? What is the most common thing that comes to your mind? What is the most common primary orbital tumor? It is Rhabdomyosarcoma. So it is Rhabdomyosarcoma. Now the diagnosis has been made. Look at this. Most common primary intraocular tumor. Embryonal type carries very good. This type, there are the three types, no? Embryonal, alveolar and botryoid. Embryonal, alveolar and botryoid. These are three types of the rhabdomyosarcoma. Embryonal, very good prognosis. So this is the true. Alveolar, worse prognosis. Botryoid, बीच का होता है. Regarding prognosis, most common site is supranasal. As you can see, it's a supranasal area only. So obviously this is the most common site. You have to remember. Most common site of metastasis is lung and bone. Yeah, it's right, it's true. So what is not true is here. Why it is not true? You must be amazed. Just read the line. It is the most common primary intraocular malignancy of childhood. Do you think it's the right statement? Intraocular. This is orbital. It's extraocular, na? This is orbital, not intraocular. So it here, instead of this primary orbital, if written, it would have been the right option. But intraocular tumor. It's a false statement. So what is right? It is the most common orbital malignancy, primary orbital malignancy, and most common sarcoma of the childhood also. So what is the most common primary intraocular tumor? Most common primary intraocular tumor is retinoblastoma, right? Moving to this 15th number question. Very common. The picture is showing here. True except Art's line present in the subtarsal conjunctiva. Obviously everybody knows that this is a trachoma. Art's line is present in subtarsal conjunctiva. This is the right option, caused by the chlamydia D to K serova. Prognosis to the corneal opacity requires surgical treatment. In safe strategy, E stand for the environmental improvement. Actually, this is the papillae. This is actually the follicles. You can see here. Here, the subtarsal conjunctiva mein this area of fibrosis is representing the Art's line. Here this is Art's line, and you can see this Herbert Peets also. So obviously this is the trachoma, and trachoma is caused by the serover A, B, BA and C. A, B, BA and C, not by D and K. So this is the false here. Subtarsal conjunctiva में Art's line होता है. This is true statement. This is wrong. Prognosis, if there is a corneal opacity, obviously if there is a corneal opacity, I will tell you about this, then there is a surgical treatment should be there. Yes, E represents for the environmental improvement in the safe strategy. Okay, then S is what? Surgery, antibiotic, facial cleanliness and environmental improvement. surgery, antibiotics, azithromycin, single dose 1 gram, facial cleanliness, environmental improvement. This has been asked in the recent INCT examination. Now coming to this WHO grading, FISTO grading, you can also remember it by the FISTO. FISTO. Okay, this is F, this is I, this is S, this is T, this is O. FISTO. Remember this: follicles, trachomeltus inflammation follicular. Whenever it is present more than 5, this is important, 5 or more in the superior tarsal conjunctiva. This has been asked on the examination. That's why you have to remember 5 or more in the superior tarsal conjunctiva and more than 0.5. This is very important to understand. So that then it is called the follicle. Then there is an intense inflammation, then there is a scarring, then there is a trichiasis, means inward movement of the eyelashes touching the cornea, trichiasis. And this constant touching of the trichiasis lead to the corneal opacity. So you have to treat trichiasis by removing the eyelashes, and opacity by obviously surgical intervention you have to do. And now chlamydia trachomatis, A, B, B and C. Serover is causing the trachoma, and this is causing the other genital conditions. Okay, so this one D2K is causing other genital condition. Rest of this chlamydia trachomatis, LGV, lymphogranuloma venerum. You have to remember this. This is the classification of the chlamydia trachomatis. So in this way, we have come to the end of the part 1, and we will soon upload the part 2 of this image on ophthalmology. That is very important to understand. I hope you like this, and if you have any doubt, just comment on the comment section and subscribe this channel, spread this over your friend, and discuss the questions. If you want to discuss the questions of this, because this is actually helpful for the coming examination. So before the coming examination, I will be uploading complete part of this image in ophthalmology. So do watch the video and subscribe and click the bell icon. Thank you. This is Mehboob, Dr. Mehboob, MD Ophthalmology from AIIMS New Delhi, signing off. Thank you.